Hello, everyone. Welcome to our Zoom meeting. And today we will have a couple of items in our agenda. When you are ready, Dr. Shahidin and your team, you can go straight and start, please. Thank you.
Hello everyone, I am Dr. Salahuddin Abdalhamid, the leader of the RIGHT team, and I'm excited to welcome you all to our weekly presentation. So we have 4 topics prepared for today, and each will be delivered by one of our team members. The first topic in our agenda is understanding the cardiovascular disease in the aging population, and it will be presented by Dr. Ula. And the next topic, it's about how to start focusing group design insight from dementia caregivers, and will be presented by Dr. Mahasin. And the third topic is about using a Plagiarism Checker, a practical guide, and will be presented by Dr. Sabry. And finally, the last topic is about 12 ways to make a work a better place, and will be presented by Dr. Iman. And at the end of our meeting, Dr. Nader will give us some updates about research projects. So let's start by first topic. If you are ready, Dr. Ola.
Yes, I'm ready, Dr. Sabah. We can start now.
Okay, you can start. Go ahead.
Assalamu alaikum. Good afternoon, everyone. My name is Abdalrahim. I will be presenting the topic on cardiovascular effects, the cardiovascular diseases. Okay.
Okay, go ahead and share your screen, please.
Okay. You can see my screen?
Yes, we can see it very well.
Okay. So today I will be talking about cardiovascular diseases. So this topic is divided into 2 parts. The first part, which I'll be talking about today, it's about the epidemiology, the effects of aging on cardiovascular function, the cardiovascular risk factors, the coronary artery disease, acute coronary syndromes, and chronic coronary artery disease. The second part, which will be about valvular heart disease, cardiac arrhythmias, and peripheral artery diseases, will be covered in a separate session. Okay. So let's start talking about today's part. We talk about epidemiology. So among 800,937 deaths in the United States, actually from cardiovascular diseases, it has been estimated in the year of 2013. 81% had occurred in adults who are 65 years of age and older, and 56% of those occurred in those who are 75 years of age or older. Okay, with the aging of the population, the absolute number of cardiovascular deaths in older adults is expected to increase markedly over the several decades. So, the prevalence of cardiovascular disease has been divided into different age cohorts, and each age cohort is divided into male and female. And as you can see, the prevalence of cardiovascular disease tends to increase progressively with the age till it exceeds about 80%, about 85% in patients who are older than 80 in men and in women. Okay. So, what are the principal effects of aging on the cardiovascular system? First, there's increased arterial stiffness, which will lead to increased afterload and systolic blood pressure. There is decreased myocardial relaxation and compliance, which will lead to increased risk of diastolic heart failure and atrial fibrillation. There is also impaired responsiveness to beta-adrenergic stimulation, leading to decreased maximum heart rate and cardiac output and impaired thermoregulation. There's also decreased sinus node function and conduction velocity in the arterioventricular node and the infranodal conduction system, eventually leading to increased risk of sixth sinus syndrome, AV block, left anterior ventricular block, and left bundle branch block. Also, we have impaired endothelium dependent vasodilation, which leads to increased demand ischemia and risk of coronary artery disease and peripheral artery disease. There is also decreased responsiveness of baroreceptors, which will increase the risk of developing orthostatic hypotension, fall, and syncope. And lastly, there is a decreased exercise response as in decreased maximum heart rate, maximum cardiac output, VO2 max, coronary blood flow, and peripheral vasodilatation. This eventually results in decreased exercise capacity and increased cardiac implications like ischemia, heart failure, shock, arrhythmia, and death with illness. So, to summarize the effects, we have increased arterial stiffness, decreased myocardial relaxation and compliance, decreased responsiveness to the beta-adrenergic stimulation, impairment in the conduction system of the heart, impairment of the endothelium-dependent vasodilation, decreased baroreceptor responsiveness, and decreased exercise response. Okay? Likely, in healthy older adults, these age-related changes have modest clinically relevant effects on the cardiac hemodynamic and performance at rest. So at rest, the resting heart rate, ejection fraction, stroke volume, cardiac output, they are all well preserved, even at very advanced age. But unfortunately, the ability to respond to the increased demand that can be associated with exercise or illness decreases progressively with advancing age, okay? So what are the major risk factors for cardiovascular diseases? We have 4 major modifiable risk factors: hypertension, diabetes, dyslipidemia, and smoking. So the higher rates of cardiovascular disease in older patients, as in absolute number of cases per risk factor, tend to increase with age. If we have like a population of patients with hypertension that are young compared to a population with hypertension that are old, the proportion of people with cardiovascular disease is more in older population than in the younger one, okay? And if we have multiple risk factors as in smoking and hypertension together, and plus the age-related cardiovascular changes that could further help to promote and develop the progression of heart disease and vascular disorders. So talk about hypertension. So the pulse pressure, which is the difference between systolic and the diastolic pressure, tend to increase with age. As we mentioned earlier, there is increased arterial stiffness, which will lead to increased systolic blood pressure. So isolated systolic hypertension become the dominant form of hypertension in older adults. The SPRINT trial actually demonstrated that a reduction in risk of major adverse cardiovascular events and all-cause mortality was more intensive. Systolic blood pressure lower in patients at increased risk cardiovascular risk, particularly those who are 70 years and older. So if you have more intensive systolic blood pressure lowering in patient with risk of cardiac diseases, this will reduce the risk of major adverse cardiovascular events and all-cause mortality. Okay. Actually, the guideline of 2017 demonstrated that if a patient has a blood pressure of 130/80 or more, and also have an estimated atherosclerotic heart disease risk of about 10%, as in patients who are older than 75 of age, they should receive pharmacological therapy. The other risk factor we have diabetes. So diabetes tend to double the risk of heart disease in patients, regardless of their age, old or young, but it further increases the risk with age. As in Framingham study, the excess risk associated with diabetes was greater in both men and women who are 75 years of age and older than in younger individuals. Despite this risk, the ATS has recommended that for older adults with multiple chronic conditions and activity of daily level impairment or cognitive impairment, more lenient hemoglobin A1C targets, for example, less than 8%, are responsible given limited life expectancy and the risk of hypoglycemia with aggressive therapies. Then we have dyslipidemia. The most important cholesterol that we're concerned about is the HDL cholesterol. So low level of HDL cholesterol of less than 40 milligram per deciliter in men and 50 milligram per deciliter in women, and high ratio of total cholesterol of HDL cholesterol total cholesterol to HDL cholesterol as less than 5.5 in men and 5 in women are independently associated with coronary events among adults for at least up to the age of 85. So clinical trials have demonstrated the benefit of statin therapy in moderate and high-risk patients up to the age of 85. The last major risk factor we have smoking. So the prevalence of smoking declines with age, particularly can be due to successful smoking cessation or can partly be due to premature death in smokers. However, among older smokers, so smoking cessation is associated with substantial reduction in cardiovascular risk. In most studies, smoking remains a strong and independent risk factor for cardiovascular events among older adults. So these are the four major risk factors: hypertension, diabetes, smoking, and dyslipidemia. We have additional risk factors, include low level of physical activity. This one's actually associated with increased risk of cardiovascular and all-cause mortality in people of all age group, not only adults. We also have pre-frailty and frailty, and we have obesity and coronary artery calcium content and seating. So talking about the epidemiology of CAD, we have the mortality after acute MI tend to increase with age, and the prevalence of clinical coronary artery disease increases with age in both men and women. The incidence of angina pectoris peaks between the age of 65 and 84 and decreases modestly thereafter, and 2/3 of all MIs, excluding silent MIs, occur in adults who are 65 years of age and older. Now talking about acute coronary syndrome. So the acute coronary syndromes are unstable angina, then ST elevation myocardial infarction, ST elevation myocardial infarction. Usually unstable angina and then ST elevation myocardial infarctions are considered together because they are pathophysiologically similar and can clinically, they're pathophysiologically and clinically similar and difficult to distinguish at the time of presentation. We can distinguish them depending on the analysis of the cardiac biomarker proteins. So the presentation of acute coronary syndromes, the most striking symptom that comes to your brain when thinking about acute coronary syndrome would be chest pain, but the proportion of patients who present with chest pain tend to decline with age, especially after the age of 80. Luckily, we have other symptoms that become bigger in older patients, like shortness of breath, which is the most common initial symptom in patients who are older than 80 to 85. We have other symptoms like altered mental status, confusion, dizziness, and syncope. These symptoms are more dominant in older population. And unfortunately, the presentation delay, the alto symptomatology, and the non-diagnostic ECG often delays the initiation of treatment in this age category. Now talking about the therapy of acute coronary syndrome. So all patients with suspected acute coronary syndrome should immediately receive aspirin, 160, 325 milligrams, regardless of their age. The second step is to maintain oxygen saturation of at least 92%. If it drops below that, oxygen should be administered. Patients who have ongoing chest pain should receive sublingual or IV nitroglycerin, and less indication of right ventricular infarction, because we know that people with right ventricular infarction tend to have low blood pressure, and nitroglycerin is notorious for low blood pressure as well. So this may put the patient at increased risk of shock. So it can only be given if there's no contraindication. If nitroglycerin failed to relieve the chest discomfort, we can follow it by IV morphine. The next step is to add another antithrombotic agent. We get to use the appropriate antithrombotic agent for the patient depending on their overall health status and their comorbidities. But usually a B2Y12 inhibitors are most commonly used, especially clopidogrel. We can use enoxaparin and fractionated heparin, but they should all be stopped after revascularization. Okay. We have an anticoagulant that can cause increased risk of bleeding in patients who are older. Be careful when you and not to use those in elderly patients, like prasugrel. The most important step after that is reperfusion therapy. So reperfusion therapy is done with one of either two ways, either percutaneous coronary intervention or with fibrinolytic agents. It is indicated in patients presenting within 12 hours of the onset of the ST elevation MI, as in class 1 recommendation, or within 24 hours if there are signs of symptoms of ongoing ischemia, as in class 2A presentation recommendation. Risk of intracranial hemorrhage after administration of a fibrinolytic agent increases with age, especially after the age of 75, and it's higher with fibrin-selective agents like DPA, which is commonly used, and reteplase, and then the non-selective agents with streptokinase. Overall, BCI is the preferred method for reperfusion strategy. It has been associated with severe outcome relative to fibrinolysis in patients up to the age of 85, provided that it's performed within 120 minutes of the patient arrival to the hospital. Make sure that this is within patient arrival to the hospital, and we're talking about reperfusion should be generally done within 12 hours within the onset of symptoms, okay? So to summarize how we treat a patient presenting with acute coronary syndrome, we use aspirin, and then we maintain oxygen saturation. We can give nitroglycerin or IV morphine, add on another thrombotic or anticoagulant agents, perform reperfusion therapy. After a documented ACS, patients should be maintained on aspirin, a beta blocker, ACE inhibitor, and statin therapy in the absence of any contraindication for these drugs. Okay, clopidogrel 75 or ticagrelor 90 milligrams. They should be is recommended for at least 12 months for all patients with ACS, regardless they use BCI or not. And if feasible, we refer a patient to a structural cardiac rehabilitation program. One point about beta blockers, they should be used in the immediate post-infarction period because they help reduce the risk of malignant ventricular arrhythmias. They reduce the size of the infarct, and they help to inhibit remodeling. But it should be received post-revascularization. If it's received prior to that, it's not shown to help to improve outcome, and it might even increase the patient risk of developing cardiogenic shock, especially in patients with large infarct size and patients with signs and symptoms of heart failure. Okay, now let's talk about chronic coronary artery diseases. So older patients are more likely than younger patients to present with exertional fatigue or shortness of breath and the classical angina vectors. We've mentioned this point before, and also older patients tend to have more severe and diffuse coronary artery disease, like more triple vessel disease, left main coronary artery disease with high prevalence of prior myocardial infarction and left ventricular dysfunction. So the diagnosis of chronic coronary artery disease is generally similar in older and younger patients, but older patients have on average a higher pretest probability of significant coronary obstruction. As a result, false positive rates and stress tests tend to be lower in old patients, while false negative rates tend to be higher. Okay, most patients with stable symptoms likely to be due to coronary ischemia, and stress test is the initial diagnostic test of choice. So one of the things that could be contributing to the high false negative rates in elderly patients is that they have decreased capacity to exercise, which the response to exercise is going to be reduced, as we've talked about earlier. So they're not going to reach the maximum heart rate that we need to induce in order to show the signs and symptoms of ischemia. Luckily, we have other diagnostic tests we can rely on, like pharmacological stress testing. We can use nuclear scanning and angiography. Just make sure to use the appropriate diagnostic methods that is appropriate for the overall patient health status and their comorbidity. So if we're trying to reduce the progression of CAD, we need to first we need to treat comorbidities according to the guidelines, and then to control the risk factors. Like first, we need to encourage stopping the use of tobacco products, prescribe a Mediterranean diet, which is a diet low in saturated fat, cholesterol, and it should be high in fruits, vegetables, and low grain and whole grain products. We should encourage at least 30 minutes of aerobic exercise, such as walking for at least 5 minutes, 5 days per week, and advise modest weight reduction for patients who are mildly obese with a BMI of 35 kilogram per meter square. The next step, we can provide medical therapy, which include aspirin, 75 to 162 milligram, Also, statin therapy is indicated for all patients. So statin therapy is given regardless of the pre-treatment LDL cholesterol. The current guideline recommend use of moderate to high intensity statin like atorvastatin 40 to 80 milligrams or roxastatin 40 to 80 milligrams. It's no longer recommended to treat the specific cholesterol targets. Instead, advised therapeutic decisions based on the predicted cardiovascular risk. ACE inhibitors also given, they help to reduce mortality and cardiovascular morbidity in patients up to the age of 85, especially those with coronary artery disease, peripheral artery disease, or diabetes. They are recommended for most patients with established coronary artery disease in the absence of contraindications who also have hypertension, diabetes, left ventricular ejection fraction of less than 40%, or kidney disease. They should also receive beta blockers for at least 3 years after an MI in the absence of its contraindication or limitation of adverse effect. These beta blockers, they're indicated for all patients with left ventricular ejection fraction of less than 40%, regardless of the cause of the reduced ejection fraction. And the one that have been to improve mortality are metoprolol, carvedilol, and bisoprolol. They are also the most effective anti-ischemic agents and should be considered the medication of first choice for treating angina symptoms. Other anti-ischemic medications are calcium channel blockers, long-acting nitrate preparations, and ranolazine. They can be used as first-line therapy in patients who cannot take beta blockers or can be used in combination with beta blockers. Okay. The final step is revascularization. So revascularization is in chronic artery disease, the principal indication for revascularization are to ameliorate symptoms that have not responded to medical therapy and to reduce mortality in select patients who have high-risk coronary disease or ischemic cardiomyopathy with reduced ejection fraction. So the complication rates, including mortality, increases with age, both after percutaneous intervention and coronary bypass surgery, especially among patients who are older than 80. In comparing percutaneous intervention to bypass surgery, the long-term outcomes are generally similar, but the short-term mortality, major complication rates, including cognitive dysfunction, hospital stay, and convalescence time, they're all increased with the surgery relative to BCI. However, the need for subsequent revascularization procedures and late mortality are actually higher after BCI. In select patients with diabetes multivessel or left main disease, surgery appears to be associated with better outcome than BCI or medical therapy alone. However, the benefit and risk of all therapy options like medical therapy, BCI, and bypass surgery, they should all be discussed with the patient to decide the best course for treatment for the patient. So, what are the risks of bypass surgery? Up to 50% of patients who undergo bypass surgery using extraoperative circulation experience measurable cognitive impairment after the surgery. This could completely resolve after 3 to 6 months, but a small percentage could have persistent symptoms of cognitive dysfunction. Also, functional decline is common and can be irreversible. To minimize this, we should start rehab early in the hospital and start patient structured cardiac rehab program after discharge. So, to summarize, aging is associated with extensive changes throughout the cardiovascular system that leads to progressive decline in the cardiovascular reserve capacity, substantial alteration in the clinical presentation, the response to therapy, and the prognosis of cardiovascular diseases. Older adults account for the majority of the hospitalized patients with acute coronary syndromes, and about 80% of deaths attributable to acute coronary syndrome tend to occur in patients who are 65 years of age and older. Although the benefit of current treatment for acute coronary syndrome are generally similar in older and younger patients, older patients are at increased risk for major complications from therapeutic interventions. Okay. So this actually concludes my presentation. If there are any questions or additions, I'll be happy to address.
Thank you, Dr. Ola, for this great presentation. So, if anyone has a question or would like to add something, please feel free to unmute your mic.
Thank you so much for great presentation. This is an important topic and everyone should pay attention, and hopefully you will see and be able to manage patients with these conditions. Thank you so much. Great presentation.
Thank you so much. I hope it was useful.
Thank you, Dr. Ola. Since there is no further questions or comments, let's go ahead and move to our next topic. The next presentation is titled How to Start a Focusing Group, Design Insight from Dementia Caregivers, and will be presented by Dr. Mahasin. Dr. Mahasin, please go ahead. Mic is yours.
Assalamu alaikum, everyone. My name is Dr. Mahasin. I'm gonna present the next topic, inshallah.
Wa alaikum salam.
Okay, is it my screen is clear for everyone?
Yes, it's clear.
Okay, I'm gonna start by give you guys an introduction about how to start a focus group for music therapy app. Okay, focus group are more than just structured conversation. They are powerful tool for uncovering qualitative insights, especially product development. They play a key role in understanding the unique needs of users. For example, Mert et al. 2025 demonstrate how focus group help improve the usability of music therapy for dementia caregiver. And this is concept user centered design is not just about aesthetic. It's about creating healthcare technology that truly meet real world demands. Okay, this is our agenda of the presentation. Okay, proposed driving design for the caregiver. This study reflects deep commitment to supporting those who care for individuals with dementia by focus of useful app design, tolerated to caregiver unique challenge. It highlights the importance of the participantly design principle, involving user in the development of the process, ensure the final product address their actual needs. Real-time feedback become a key design driver. Help build an app that feel genuinely useful for audiences. Okay. Okay. Define the right participants. Okay. The right participants for this study. Okay. To be sure, the success of the focus group depend on selecting the right participant. In our case, that meant recruiting both family and professional caregivers, as well as rehabilitation therapists. This is diversity provided valuable perspective on the app design. We also assess the participant comfort with the technology to ensure mindful engagement during the trial, and the screening process in enhancing the quality of the feedback and allow for deeper, more focusing discussion. Okay. Ensure relevant. Okay. Ensure the relevant. Sorry. Okay. Ensuring relevant and engagement. To ensure participants could engage fully with the app, we carefully consider their background, include their rules and technology fluency by selecting individuals who closely match our user base. We ensure the feedback we gathered would be both relevant and actionable. This step lead to the strong foundation for usability inside. We aim to catchable. Okay. Strategic participant recruitment. Effective recruitment require multi-approach. We use social media, caregiver support platform to search the right people. Before each session, we send out survey to gather demographic information and assess technological skills, helping us in our approach. Participants, we were sent a 15 bucks, not just as a give sorry, but as acknowledgement of the value of their time and insight. The strategy contributed to higher participant and more engaged conversation. Okay. A thoughtful approach of the participant. Our recruitment strategy was not only about the number. It was about creating an inclusive and respectful process. The pre-session survey helped us to understand the participant better and the competition reinforced our participant for their contribution through. There's a step support. There's a step supported a more positive, productive research experience. Okay, designing effect focus group session to make the session productive and inclusive. We held a 90-minute visual meeting structure around open-end question, moderated, followed and consistent guide to ensure all key area were covered. One highlight was the inclusion of the clickable prototype, allowing participants to directly interact with the app and offer hand-on feedback. This interactive approach brought out richer insight that might have been missed in purely conversation format. Okay, here, turning dialogue into design. Analyze focus group discussions is where a raw feedback become actionable insight. With the participant consent, we recorded and transcribed each session for details review using coding, and we allow them to emerge naturally rather than force them into category. We also compare them across the participant rule to deepen our understanding and ensure as well-rounded interpretation of the data. Okay. Best participant in analysis. Following the best and following best best particles in data and analysis ensure our finding were both impactful. We began by setting clear analytic goals and individual multi-coder to reduce the bias. As new data came in, we continuously refunded our them. Okay. Okay, sorry. Okay. Ethics in focus group, and an uphold ethics standard was priority through this study. We ensure all participants prove informed consent, and we were fully aware of how their data would be used. Respective privacy and for respective privacy and supportive environment build the trust. Encourage honest and open feedback. These principles were foundational to both participant satisfactions and the research. Okay. Managing group dynamics. Facilitating a successful focus group also means navigating interpersonal dynamics to avoid dominance by voices. We use techniques like round robin sharing with sensitive topics. Arouse, we prioritize creating safe and respectful space. Interactive tool and verbal questions. Technically keep it engagement high and ensure all perspectives were heard. Okay. Continuing the conversation, follow-up was important part our process. Staying in touch after a session helped reinforcing participant valuable to the project and open the door for additional insight. These ongoing relationships not only included our understanding, but also frustrated a scene of the community and collaborated around the app's development. In conclusion, the valuable of the participatory designs, our exploration of focus groups underscore their critical role in creating effective healthcare application by embedding caregiver voice into the design process. We gained a deeper understanding of their needs and challenges. The step-by-step approach outlined here, from the participant recruitment to analysis, provided blueprint for meaningful user engagement. Ultimately, focus groups are more than a research method. They are vital part of design technology that truly it's for user. Thank you.
Thank you. Another great presentation. Any questions?
Thank you.
So for this topic, I want to share with you that in 2020, we published an article in Healthcare. It's a big journal. So what we did, my team and I were interested in the use of technology or adaptation of the technology in older adults. So we have a community of older adults where they live in an independent living kind of community. And then we have the young towards older adults who are either working at the university or other places around the dancing area. So we have two groups. So we met with the first group, the older adults, and we discussed the same way the method that was discussed now. So we have some items that we went through, and we collected their perspective, their attitude, or their use of technology, and we did the same with the second group. And we finally collected all the information, analyzed all the data, and then presented it in an article that was published. So you can do that even within your group. Let's say the attitude towards technology, AI, for example, in international medical graduates in this group, or in general in medical versus dental graduates, and so on. So you come up with some idea, some question, and identify your group, and then you can make a meeting and discuss, see what their perspective, how they use the technology, and what's the risk, what's the benefit, and so on. So you collect all this information and then analyze it, and then you can make either a poster that can be presented in one of the conferences, which is the shortest way, speedy way, or you can do it as we did. You can write a manuscript, submit it, and publish it as a paper. But thank you so much.
Thank you, Dr. Nader, for sharing this information with us. And thank you, Dr. Mahasin, for your wonderful presentation. So before we move to our next topic, I would like to highlight why this upcoming topic is especially important. In academia and professional setting, plagiarism, by definition, the act of using someone else's words or ideas or work without proper acknowledgement. It's remained one of the most prevalent and serious issues. Many students, researchers, and even professionals unintentionally commit plagiarism due to lack of awareness or access to proper tools. So it can lead to rejection of your paper, and damage your reputation, or even legal consequences in some cases. So that's why it's so important to know how to detect and avoid plagiarism effectively. So learning how to properly check your work using reliable tools is no longer optional, it's essential. So with that in mind, our next speaker, Dr. Sabry, will take us through a practical approach to using plagiarism detection tools. Dr. Sabry, please go ahead. Mic is yours.
Thank you very much, Dr. Salah. Thank you very much, all the presenters. And thank you very much, Dr. Nader, for this great opportunity. Please confirm with you, can you see my screen and is my voice is clear?
Your voice is clear and your screen is clear, okay.
Okay, that's awesome. So let's start by introducing myself. I am Sabry Saeed. I graduated from International University of Africa back in 2024, and I'm happy to be here along all the doctors in TGRF. Today, our topic is understanding plagiarism in research. As my colleague, Dr. Salah mentioned, plagiarism is a very serious topic nowadays. Why? Because as you all know, nowadays we have a lot of AI tools, AI that can generate a video for you, like literally a video from no one in the whole world. So in that being in mind, can you imagine what they can do for you in a research field? They can generate a whole manuscript, not only a paragraph or only a sentence. So using that in an unethical way will put you in a very serious position in the academic field, and both in your clinical field as well. So the definition of plagiarism is the act of using someone else's work or ideas without a proper acknowledgement, which seriously undermines academic integrity. So this is the whole problem, or the whole issue of plagiarism, is someone being in the research field. For example, he's new in the research field, and he's for example gotten a task for like writing introduction, let's say, or writing the abstract, or writing whatever segment or section in the manuscript, and he don't have like the skills needed for the academic writing. So he like entered the PubMed, the other databases, and copied some of the important information regarding his topic, and he pasted it directly in the draft of the manuscript. This will be a very serious problem, not for him only. It will be a serious problem for the whole group. The consequences of plagiarism. Now, this is the real problem. Engaging in plagiarism can lead to repercussions, including loss of funding, damaged reputations, and academic penalties. This is a very important point. Academic penalties might even reach a level of a blacklisting that any small journal cannot accept your manuscript further away. The importance of original research is essential for advancing medical knowledge and ensuring the integrity of scientific contributions. So we all want to enhance our CV, but not on the just way of we want to enhance our CV. So we have to do something that is unoriginal, or something that is plagiarist. So and I think you heard that they just published an research index for like rating the research in each universities. There is a lot of other measures that you can go Google it and find it. Maintaining academic integrity, avoiding plagiarism, ensure that your work is credible and respected in the academic community, fostering a strong professional reputations, which means whenever you are acting on a manuscript and carry in your mind that I have to put a new evidence, or to generate a new evidence in the medical field, this will increase your chance not only in the CV, that improving your CV, but only will increase your chance in getting another position or another opportunity in the research within the area that you are interested in, for example, internal medicine. The second thing is enhancing research skills. Understanding and avoiding plagiarism helps international medical graduates develop critical thinking. This is a very important point, and writing skills. And this specific skills, writing skills, I saw it in myself. The first manuscript that I wrote, it took me, the sections was the introduction. Introduction is considered the easiest section in the manuscript. It took me like for 1 week to complete only the introduction. Nowadays, I can complete it in 1 day. So it will enhance your research skills for sure. Building trust with peers. Original research foster collaboration and trust among colleagues, facilitating a supportive environment for knowledge sharing and innovation. About plagiarism checkers. Tools to ensure research integrity. Plagiarism checkers help maintain originality in research by detecting copied content and ensuring compliance with ethical standards. So what is this all about? We have some softwares that are AI generated that can be used, and some of them are already published before the AI era also. So these softwares we can use to check our manuscript or our original paper or manuscript for the plagiarism. For example, we completed the introduction part and we just want to make sure that it is not plagiarized. Now, there is some percentage that is considered acceptable in the medical field in some journals, which is considered like a low quality journal, but still it's considered a publication for you. I will talk about this percentage later on. And these plagiarism checkers are very nice, and they will give you like real life examples at the end of this session. So the step one, understand what constitutes plagiarism and its consequences. The first step, when for example, you are applying for a position in research through LinkedIn, let's say, or through Facebook, or through WhatsApp groups, or even here in our Geriatric Research Fellowship, you have to carry in mind that there is something known as plagiarism, and what is the consequences for me and for the whole group in this matter. And then step two, utilize plagiarism checkers to verify your work originality, like the softwares that we just mentioned in the previous slide. Step three, always cite sources properly to give a credit to original authors. Referencing is very important. Any information that you took from the PubMed or from other research papers, you have to cite them very well. And nowadays it's very easy. You can just click cite on PubMed. They will give you the citation directly, which you can copy and paste in your references at the end of the manuscript. Step four, review and revise your writing to enhance authenticity and clarity. And this is a very important point. I just want to emphasize this because I just been through this position in which reviewing your manuscript multiple times will definitely enhance your skills in writing. Why is that? Because, for example, in the first revision, you find like, let's say, you just cut the clutter. There is a lot of words that does not mean anything, and that does not increase the meaning of the sentence. You cut them in the first revision, and then in the second revision you find some of the mistakes, like in the commas and in the dot spot. All of them you can revise them and enhance them. And even in the words themselves, you can find another better word which is considered academic rather than the usual daily words. So this is a very nice quote. Using a plagiarism checker has made my research more credible and reliable. This is by Dr. Sabry. She's an international medical graduate researcher. This is very, very true, by the way. So protect your research, maintain integrity and originality. Take action now to ensure your work is original. So let's go, guys. And I have two videos here for you. And I think for the time's sake, I will share them in the group so you can watch them by yourself. I just want to share with you the real life, the real life software. It's known as X-Checker. It's very nice. Just give me 1 minute to share it. Can you guys see the software now, Plagiarism Checker?
Yes, it's clear.
Thank you very much for confirming that. So now let's go and take one of the texts that I took directly from a manuscript in PubMed. And let's see what it's gonna say. So this is the software. This is the main page of the software. Whenever you download it and you will make an account through your email, you will activate it through your email, and then you can just get your text or your paragraph and paste it here. It has a limit of 120 words per each check. So now it will give me like, yes, free versions can only first 120 words. There's a paid version in which it's unlimited. So let's see. Can you guys see the pie chart?
Yes.
Awesome. So this is the percentage of plagiarism that is now in my text or paragraph that I took directly from a paper in PubMed. If you can see now here, the dark blue one is called plagiarism 19%. And the uniqueness is 81%. So now, so why is this unique 81%? So 81% is considered a high uniqueness. In some journals, it is acceptable even. But the problem is that I took the paragraph from introduction, and introduction, it has a general information. So that's why it's called, that's why it showed me a unique. But also this is a consider a high level of plagiarism, 19%, because most of them like consider less than 15, it's acceptable. So let's go back now and see what if I took the paraphrased part of the same paragraph, in which I took the same paragraph, I paraphrase it, and now I want to see what the checker will tell us. Okay. Awesome, great. So can you see, guys, the difference? The previous one was 19% plagiarism. Here, there is no plagiarism at all. It is zero. Despite the information are the same. But I changed the words, I changed the sentences, I changed the description of the information or the real, in fact, infos that provided in the same manuscript. I took the information that I need, and then I paraphrase them, make them academic, and I paste them here. Uniqueness is 100%. So this is a very good for the plagiarism in all of the journals. So that was all. I will send you the link for the other tools in the WhatsApp groups later on. And I hope you guys enjoyed this presentation. And I have one last note. The 1 million question for this presentation: can we use AI tools for paraphrasing? And the short answer is yes. For paraphrasing, we can use the AI tools, but we have to double check again. Like if you use a paraphrasing tool, AI paraphrasing tool for some paragraph or text or sentences, then you have to take them and paste them here or whatever other plagiarism checker you use to check only the percentage. If is it okay, you are good to go. Thank you very much for listening.
Thank you so much, Dr. Sabry, for your excellent and valuable presentation. The topic of plagiarism is extremely important, and you explained it in a clear and practical way that we can all benefit from. I also want to say that it was truly a pleasure working with you. You are not only a knowledgeable, but also a kind and supportive person, and I highly recommend everyone to get to know Dr. Sabry. He is someone you will really enjoy learning from and working with.
Thank you very much, Dr. Salah, for your honest and your kind words. It's really an honor to work with you. Thank you very much.
Thank you, Doctor. Thank you. So with that, we're now moving to our final topic for today, and it's about 12 ways to make work a better place, and will be presented by Dr. Iman.
Before she starts, I just want to thank you, Dr. Sabry, for this great presentation as well. And it's important that when you are using AI to also consider what your end product and where you are going to publish. For example, if you are going to write, let's say, a simple abstract, you are going for a conference, it's better to review their author or their guidelines. Sometimes they will say, we accept AI tool as a used tool for preparation of your poster or abstract, as well as some of the journals. Let's say you are submitting a manuscript to a journal. Review the laws or the bylaws or the guidelines, the author guidelines. There is usually a page where they put what they need you to use as a format for how to submit your manuscript. So in that, some of the journals will say, we don't accept any articles that the AI was used, or maybe we can accept 20%, something like that. So they will run the detection method, and if they have a threshold and is below that threshold, that's fine. But if they reach the threshold, let's say 90%, then they will say, oh, we will reject this article or this manuscript. So just pay attention. Thank you so much.
Welcome. Thank you very much, Dr. Nader.
Appreciate it.
Thank you, Dr. Nader, for sharing with us this important information. So let's go ahead, Dr. Ola. Dr. Iman.
Hello, everyone.
Here. Yes.
Hello, is my screen and my voice clear?
Yep, it's clear.
Today, I will be presenting the 12 ways to make work a better place. The 12 ways, in short: number 1 is show appreciation. Number 2 is communicate clearly and respectfully. 3, foster inclusion. 4, provide opportunities for growth. 5, create a safe, comfortable space. 6 is lead by example. 7, encourage autonomy. 8, address toxicity immediately. 9, offer purpose and clarity. 10, promote team bonding. 11, encourage work-life balance. And 12, inject. Number 1 is show appreciation. Gratitude goes a long way. Recognize hard work publicly or privately, depending on what each person prefers. A quick thank you or a written note or a shout out in a meeting can make someone feel valued. You have to create a culture where peers also appreciate one another and it's not just praise. Number 2 is communicate clearly and respectfully. Healthy communication is the backbone of a strong team. Be transparent with decisions, expectations, and feedback. Practice active listening, give full attention, don't interrupt, and confirm understanding. Use kind, professional language, even when dealing with conflict or giving a tough feedback. Foster inclusion. Everyone deserves to feel like they belong. Encourage diverse opinions and create safe spaces for people to speak up. Educate the team about unconscious bias and inclusive practices. Involve different people in projects, leadership, and decisions, not just the usual voices. Encourage a work-life balance. Burnout helps no one. Support flexible working hours when possible, especially for parents or caregivers. Avoid glorifying overwork and reward smart, sustainable productivity. Be mindful of after-hours communication and respect personal time. Number 5, provide opportunities for growth. Growth is motivating. Offer workshops, training, webinars, or online courses. Provide regular feedback that's developmental, not just evaluative. Encourage people to pursue new skills, take on stretch projects, or shadow other roles. Create a safe, comfortable place. The environment matters more than we think.
encourage proper lighting, seating, and cleanliness for physical comfort, promote psychological safety. People should feel like they are comfortable taking risks without fear or ridicule or punishment. Establish and reinforce safety protocols and a harassment-free workplace. Promote team bonding. Connection makes collaboration smoother. Create low-pressure, fun ways to bond. Team lunches, birthday celebrations, or even simple coffee breaks could help in team bonding. Consider virtual options for remote teams like online trivia or get-to-know-you sessions, and encourage collaborations over competition. Lead by example. Culture starts at the top, but it is shaped by everyone. If you're in leadership, model the behaviors you want to see: humility, kindness, punctuality, and accountability. Admit when you're wrong. Vulnerability builds trust. Treat everyone with the same respect, regardless of their title or role. Encourage autonomy. Trust builds confidence and innovation. Let team members take ownership of their tasks without constant oversight. Encourage decision-making within their scope and support them even when mistakes happen. Check in regularly and make sure it's supportive and not controlling. Address toxicity immediately. Toxic behavior spreads fast if ignored. Don't sweep issues like bullying, gossip, or passive aggression under the rug. Set clear standards for respectful behaviors and enforce them consistently. Train managers on how to recognize and handle workplace conflict constructively. Offer purpose and clarity. People need to feel like their work matters. Regularly connect tasks to the broader mission or goals of the organization or the team. Set clear roles, goals, and expectations to reduce confusion. Celebrate impact, not just output, so people see the difference they're making. Inject some fun. A little fun lightens the load. Allow space for humor and informal interactions, especially during stressful projects, and let the team guide what fun looks like and don't force it. Thank you very much for listening. If you have any questions.
Thank you, Dr. Iman, for this wonderful presentation. So we have now reached the end of our session. I would like to thank all our presentations for today, Dr. Oda, Dr. Mahasin, Dr. Sabry, and Dr. Iman. Thank you all for your great effort and wonderful presentations. And special thanks to everyone who attended. We truly appreciate your time and attention. And before I hand over the mic, I'd like to thank Dr. Nader for giving us this opportunity, for always supporting us, and for creating a great environment for learning and growth. So now I will pass to Dr. Nader to share the latest updates on research projects. So, Dr. Nader, please take over.
Thank you so much, everyone, all the presenters. These were great topics and excellent presentations. So thank you. Hopefully this will be useful for all fellows in this program, and maybe you can share it with others. I was asking if anyone has any ideas or any updates as far as projects. Please raise your hand, or you can go ahead and let us know. So in the meantime, I would like to ask anyone interested in doing a research project or training. I want to ask you to add your email on the chat. So I'm going to send you some of the ideas that we can work together. So 2 or 4 or 5 can work on one project, and you can practice on that. And if you think it's useful, then you can publish. Thinking of doing some like mobile application development. It's easy. I'm going to show you how to do that, and you can just follow the same steps. It's not that difficult. So I'm going to share the screen with you guys. All right. So here we have Gemini. you can use different one of them, the machines, or one of them is 2.5 flash, that's the fastest. And then we have Canva and we have ChatGPT, and there are other artificial intelligence. So my thinking is to write a prompt that will be used to get some ideas about certain mobile applications. So here I ask the ChatGPT or the Gemini, you are an internal medicine specialist, for example, who is training IMGs. Can you come up with 5 different ideas for mobile applications that can be useful for older patients with chronic conditions? So here, if you see, I want the AI to assume a role or pretend they are the expert in an area. And I want them specifically to teach you as a cohort or train you of doing something which is mobile application development. But I want to start the idea itself or the question. It's like brainstorming. And then I want to use that concept to target a certain population here, all the adults. If you are interested in pediatric or a teenager, you can modify that as well. And then identify which condition. If you want diabetes, hypertension, in this example, I want just general, like chronic, multiple chronic conditions. So if I run that, it will come up with some concepts or ideas. Here are 5 of them. And I can run the same query here in Canva. So Canva, you can go to Canva AI, and then I think it's you can code design for me or code for me any of these conditions or this icons you can use. And here also you can use it for ChatGPT. So I'm gonna run it on ChatGPT. If you come to the Gemini, there are 5 of them. So the first one is multi-med manager or alert system. So this might be an idea, and it can focus on different sections or multiple ones, or you can use it for only one, and then you can add each feature along. The second idea is chronic care companion, and the third one is teleconnect senior, for example, cognitive boost, wellness hub, and the last one, emergency support network. So let's say I'm interested in cognitive boost and wellness hub. So I'm gonna write here, for example, create the app for number 4. So if you see, I already gave him the options to give me a list of ideas. Now the ideas are listed. I want him to, or the AI to work on that. And here the code is written. And I can use the same here. I can copy this and then give it to Canva. And it will write a different or similar one or code for application. So here, made the same medical management, breath health, COPD, asthma, heart, congestive heart failure tracker, mind, similar to the cognitive, and then my health hub. So I'm gonna say the same, create the app for number 4. And it's gonna do the same. So it's gonna write the code for me and do that. So I'm gonna copy this one. and give it to Canva. So you can use any one of these tools and it's gonna be doing the same. So it's gonna give you some ideas, maybe some topics or brainstorming, and then you can select one of them and do that. So here I'm gonna ask them to code with me. I'm gonna give the features and it's gonna write the code, the same method, and it's gonna finish and give me the product. See here we have Cognitive Boost Wellness Hub. It has some features. And then we can modify this. So if I want to add more, I can ask the AI to add more features. If I want to change the color of the app, I want it to be green, for example, I can ask that, and so on. So we can start with a basic app, and then you can modify it as well. If you go here, they're still working on it, and I can preview that. So it's not working, it's still stopped somewhere. If it's stopped, then you can just say resume or continue, and it will finish the code for you. Sometimes it's stuck in a certain area, so it will write it for you. So Canva is still working on it, and after it's done, it's going to show you the final product. Canva is kind of neat. It uses different colorful display, so sometimes it's better than just one color and paint colors. Canva might bring you some lively colors. I found it maybe useful when attracting users, the contrast and so on. But you can specify that as well. So the idea is to create a simple mobile application, hopefully in the area where you are interested in, and then you can modify it depending on what you need to do. So here's the My Health app, for example, and it's different chronic condition, arthritis, hypertension, diabetes, and so on. So the checklist and so on. Sometimes it may be working for you, sometimes it may not work. So if there is a problem, then you can ask the AI, can you debug this? Sometimes it can fix whatever problem is there, or you can you improve it. So if you ask for improvement, it will add more features, it will add more colors or whatever, and then it give you version 2. So when you are working with this, you can work in a group of 2 or 5 members and see if you want to go and work together on the same time, or each one can work individually and then you meet and then discuss. Everyone will show their own idea or final product, and then you can elect, we want this number 1, this number 2, this. You just prioritize, you can identify which one you want to use as a first product, and then second and third. When you are done doing that, then the question is, how can we make this as a useful final product? So if you have it like this, so usually I will show you how to do the code, how to use the code. So in Gemini, the code is just right there. If you hit it, and it's gonna show you the code here. So if you highlight this code, you can copy it and then share it, and you can create a web page out of it where people can access the app and test it, and they can give you feedback and improve it and so on. So this is the first step, is to how to come up with the idea how to create an app from that idea, and then how to get the code that's written for you, and then copy that so that we can create a web page where people can test it and see if there's any room for improvement, features, fonts, colors, contrast, new information, and so on. And then we can work on improving it further. And then we can think of publishing it to be used by whatever target group that you want to use it in. For example, you treat patients with hypertension. Maybe when you create the app with for patients with hypertension, you can share it with this group of patients and then see if they like it and they use it and if they have any feedback from this cohort and so on. Patients with diabetes, patients with kidney problem and so on. So let's start with using it for small groups. So I'm gonna send you this. If you are interested, just add your email to the chat group. And then we can divide ourselves to small groups, and then each group can work on different ideas to develop different apps and then share it, and then we can go to the next step. Any questions? I'm going to stop sharing the screen. And any questions about this assignment or homework or
السلام عليكم دكتور نادر.
ورحمة الله دكتور فاطمة.
بس كان عندي سؤال، كيف أعرف إذا الآب ده أصلا موجود من قبل يعني ولا؟
So it's an AI. So you can ask the AI to identify the area where you are interested. If you want to search the same topic or same idea for the app in the store, like Apple Store or Google Store, you can search for that app. If you want to create the app as a unique one, you can identify in the when you give the prompt, ask the AI to use a new version or a unique version. So it's gonna be looking in the web, see what's available, and then it will come up with new idea or new approach.
أوكي تمام.
Good question.
شكرا
I
دكتور.
have a question, Dr. Nader.
Yes, please go ahead, Dr. Ahmed.
First of all, I want to thank you for this great idea. And I have one question about the app. If I created an app on certain topic and I want to use it, for example, in a research idea, can this application be validated to be used in a research paper?
So this is the next step. It's a good question, and similar to the topic that was discussed, I think topic number 2 today. When you have the app, then you want to test it for different things. You want to test it in a user approach to see if there is any problems as far as technical problems. The icon when hit is not going to the next step, and so on. So you want to see if there is any bugs, for example. This is the first step to make sure it's clean and user-friendly and no problem. The second step is to test it in the group that you are trying to use it in. For example, I want to use it in all the adults or people over 65. So I'm gonna test it with this group and see what their feedback. Let's say they say the contrast, I cannot read the text because the contrast of the font with the background is not that clear, or the font is small. So after you've done that, then you can verify that the app is tested and user friendly, and then you can identify your sample or your cohort, and then you can use that app in that group or cohort, and then you can get the result. Before you do this last step, using it with this cohort, you need to get IRB approval, because you
Yes.
are putting something in a group, you don't want to harm them. So if you get the approval, usually it's going to be a faster one, because there is no major side effects, for example, as can be expected. But still, if you are sharing their information, accessing their data, their mobile or some, there is a possibility. So you need an approval from the IRB. When you get that, then you start sending your application to this group. When you collect their data, then you can analyze and do your research from there. You can publish it as a poster or as a paper. I hope I am clear.
Okay, doctor, it's clear. Another small question. If I use this app, how to create a reference or how to cite this app in the research paper?
That's a good.
Especially it's created by AI.
Yeah. So you want to cite it as a website. So let's say after you get the code, you can publish it in a site. For example, one of the sites is called GitHub. So you copy that code and you put it in that web site host, and it's going to be like a URL. People will just click on that URL and go to that web or that app. So that will be your reference, that web address.
Okay. Thank you so much, doctor. Thank you so much.
You're welcome. Thank you. And the good thing is when you want to develop this, you can have no limit as far as how many you can develop, and you can teach or reach as many patients cohort. And in your application, when you apply for ERAS, for example, you can mention that I developed this app with this group, I publish it and I tested it, or I work on this with this group, and your application will be unique, the ERAS application, your CV.
Okay. Okay, thank you, doctor.
You're welcome. And you can mention that it's created with the use of AI, artificial intelligence. That means you are up to date as far as technology-wise, and you will be unique among the applicants in the same group for the programs that you apply to. Thank you.
Thank you so much.
You're welcome. Any other questions? Any ideas about any of new projects or anything we can help you with, or how to improve this program for you guys? I know there are certain conferences that will be open for abstract submission in the coming days or weeks. So look forward for this, and hopefully we can participate in these conferences, and it will be helpful for you guys. So any questions, ideas, updates? If not, I'd like to thank you, Dr. Salahuddin, and all the presenters from today. These were great presentations. Thank you so much. And I'd like to thank all attendees of today's meeting, and those who will come and watch the recording in the future. Thank you in advance. Have a wonderful day. We'll see you next week, hopefully, inshallah. Assalamu alaikum. If you have any questions, please reach out and email or contact me, call or text or WhatsApp. Thank you. Fi amanillah.
Assalamu alaikum.
Assalamu alaikum, doctor. Thank you so much.
Thank you for this opportunity.
Thank you.
Thank, thank you.
Thank you.
Thank you so much.
Thank you, Dr. Nader.
Thank you so
Thank you,
much.
Dr. Nader. Thank you so much.
You're welcome. Thank you so much.